Good evening, everyone from India. I, Dr. Gagandeep Kaur, welcomes you all wholeheartedly to Global Interdisciplinary Summit 2020, co-hosted by Global Outreach Medical and Health Association. So, moving on to the sessions of the day, again, the most power-packed ones. I welcome Dr. Omid with us. So before moving on to the session, I would like to guide all the participants that for any sort of information regarding C certificates, participation certificates, as well as the speaker's schedule, you all can log into www.gomha.org. And after that, speaking about our speaker of the day, Dr. Omid. Dr. Omid is a board certified periodontist, full-time assistant professor at the Department of Periodontology and Implant Dentistry, Tehran Azad University Dental Faculty. Fellow in Implant Dentistry from State University of New York, Dental XP. Expert at dentalxp.com. He is the author of 9 books in the field of periodontology and implant dentistry. He is also the president of International Symposium of Complications in Implant Dentistry. He is an expert and consultant at the Forensic Medicine Organization, international consultant at the Craniomaxillofacial Research Center, Tehran Azad University. He has given more than 200 lectures internationally and nationally and has done more than 70 live surgeries at official platforms. He is a fellow and master of ICOI. So with this, I would like to welcome Dr. Omid with us. And so over to you.
Thank you so much. Hello, everyone from around the world. Thank you so much for the introduction. And I'm so happy to be with you all from this platform. And I want to thank the organizers for this outstanding program with so many speakers from around the world. And again, thank you for your kind invitation. Today, I want to talk about aesthetic key secrets. I call them secrets. Actually, they are not secrets, but they are very important that we can call them secret because sometimes we forget about them. So in anterior implants, which usually we face more risk factors, more complications, and more patient discomfort if the outcome is not the way that they want it to be. So these are the things that I'm going to cover today, and to see what are the factors that can influence the outcome of our success. As the organizer presented, I'm at the Department of Periodontology and Implant Dentistry in Tehran Azad University now for about 9.5 years, since 2010. And also I have a private practice focused on periodontology and implant dentistry with my father, Dr. Omid Moghaddas. He is also periodontist, which is now, he's now in New York. And I want to tell you all that really teaching is a passion. And from the very beginning, I really thought about it. And I'm a really great fan for those people that know me of a life surgery education, because I believe that all the audience, all the dentists or specialists can exactly feel what you do and see real time with specific timing with different procedures. So the reason I bring it that usually in my CV, because I really want to be able to share my experience with all the audience, all the dentists, exactly the way that I'm doing it in my practice. And also I want to thank all my mentors over the past years that I learned a lot from them, and whatever I'm telling you from this platform, I should not forget that I learned from my mentors also. And over the past 8-9 years, I had a chance to publish 9 books in the field of perio and implant. And recently, I'm doing a translation of my dear friend Daniel Cardalopoli's book, which will be out in about 2 months. So let's go to our main topic of presentation, which is the aesthetic key secrets in anterior implant. Usually the main complications that we face in aesthetic zone are these three kind of complications, mainly the two on the right and the left, midfacial recession and papillary recession. And we really should be able to find an answer for the etiology of these kind of problems and be able to control them, to prevent them, because sometimes we can solve the problem, but it needs time, it needs cost, it needs expertise. Sometimes it works, you cannot promise. And the best way usually is to prevent. So today my focus is going to be on prevention, because I believe that very easy we can prevent these kind of complications. So speaking of immediate implants, one of the concern and one of the questions that usually may come to your mind is that, are immediate implants as comparable to conventional implants? Maybe it's a very basic question, but it's the beginning of the lecture, so we want to go step by step and answer all the questions. Well, speaking of survival rates, we have a great study, the systematic review by Ronnie Young in 2008, and it showed that the survival rate of conventional implant in 5 years is about 96.8%, almost 97%. It's a very good number, and we know all about it. What about immediate implants? Klaus Lang did another systematic review on immediate implants in 2012. It's like 8 years ago, but even in that time, with those implants, with those techniques, and maybe with those criteria that has changed over the years, again, the 4-year survivals was reported to be about 97.5%, almost 97%. So speaking of survival, they are comparable. And it's very important for a researcher, for a practitioner, when we go to the articles, really look for the criteria, not just the conclusion and the numbers. Because when we are saying survival, as long as the implant is in the mouth, it's function with no mobility, no symptom, it's surviving. It can be only 2 millimeters in bone, it can be 7 millimeters in the bone. But when we are saying reliable articles like these kind of systematic reviews, they've evaluated every important piece in the evaluation. And so maybe in these articles, only 1 millimeters of bone loss is acceptable. So numbers by themselves are not that important. The criteria behind the numbers are very much important. And also they reported no difference between the posterior and anterior zone, and no difference between the maxilla and mandible. So speaking of survival rates, we can say conventional implants can be comparable to immediate implants and vice versa. Speaking of aesthetic outcome, this beautiful study by Marco Esposito from the Cochrane database in 2010, they showed that the immediate and immediate delayed implants may be at higher risk of implant failures and complications. It's just a risk. But speaking of aesthetic outcome, they might be better when placing implants just after extraction. Why? Because we have the chance to save the height of the tissue. We have the chance to prevent the collapse firsthand. And speaking of long-term evaluation, this is a study in 2006 by Barry Ragenberg and Stuart Forum, evaluated almost 2,000 implants with almost 16 years of follow-up. And look what they showed regarding the failure rates in the posterior part of the maxilla, which we usually have more occlusal functioning, more occlusal load, less bone density, and the failure rate was only about 2%, which shows the survival of or success of about 97 to 98%. If we focus on immediate anterior implants, which is the case of our discussion today, again, we have very valuable studies by Peter Burley, by Joseph Kahn, by Edgar Elchar, Ole Grunder, all the lists you see here by Lyndon Cooper. And you can see the numbers between 97 to 100%, the survival, with all number of implants that they evaluated in the anterior zone. And in all these studies, the most critical factor which showed to be important in immediate implants was primary stability, and survival, mean about 97% was reported in all of these articles. So far we talked about these things. So anterior implants, immediate implants can be comparable to conventional implants. Survival rate is comparable, fewer appointments, decreased treatment time, and more patient satisfaction. But most importantly, we are able to save the tissue, to preserve the tissue from the collapse, from the recession, if we go in a right direction. So let's have another side of this story. Do immediate implants prevent bone loss? Can we say that if I extract the tooth and place an implant, I can prevent the bone and make sure that no resorption will happen? Well, the answer to this question is no, according to studies by Arugio Linde and Daniel Botticelli in 2004. Why the answer is no? Because always there is a part of the bone that in radiography you call it the lamina dura, in histology you call it the bundle bone, in clinic there is a very tiny layer of the bone in the crestal area. So that bone, the bundle bone, is PDL dependent. So when you extract the tooth, you're eliminating PDL. So you're not able to save that part of bone. So we cannot say immediate implants prevent bone loss 100%. No, there is a part of the bone that is PDL dependent and will resorb no matter what you do. And we have lots of studies showing that, but one of these studies, like this one, showed that the bone level at the extraction site, rather than the bone level of the adjacent teeth, dictates the level to which the bone crest heals after extraction. So no matter what's the level of the bone in the crestal area that you have, but this area is the area that usually resorption happens. And level of the bone generated into the extraction socket never reached the level at the tooth surfaces, distal and mesial to the extraction socket. This was just one study, but overall speaking, we know that the height of the bundle bone, especially in the buccal area, which usually we have the thinner bone, is about 1 to 2 millimeters of height. So it's not that easy to make sure that that height of bone will stay there and no resorption happens. So the conclusion is this: bone resorption following tooth extraction is not reduced by immediate implant placement per se. So we should see what are other factors that can have an influence, and is it possible to minimize that bone resorption or not? So would it be favorable to place an implant as soon as possible following tooth extraction? That's the question that we need to answer. Let's have another side of this question. Do immediate implants increase the risk of labial bone loss? That's another thing. So this dog model study in 2005 by Arugio Linde's group, they placed immediate implants and evaluated the buccopalatal collapse. And they showed almost about 4 millimeters of collapse with immediate implants. Also in 2009, when the Vajan did another study, again evaluating dimensional changes in immediate implants, and again they showed almost the same number, 3.87, like 4 millimeters of decrease and collapse in crestal width with immediate implants. In that specific period of time, there was a guard for immediates, and they said, let's stop it because we are losing a lot of bone. So maybe immediate implants are not good for the bone, and let's not do it or figure another way. But if we go in depth with all of these studies in those period of times, number one, they all tend to use wide implants to completely fill the socket. Number two, all of those implants were in contact with the buccal bone. Number three, none of those implants, or we can say most of those implants, were not platform switch. And number four, they all reflected the flap to place an implant. So can any of these factors have an influence on the risk of resorption and collapse of the ridge of the extraction socket after extracting the tooth? So can we minimize the loss? That was our introduction, our background about the survival, about why we are looking for some critical issues and factors that can have an influence on the outcome that we're going to gain. So now I want to review for you the 9 critical factors that I believe are most important in minimizing the risk, in maximizing the success, especially in the aesthetic zone, which we usually have more risk factors. Number one is facial plate thickness. According to this study by Vivian Capius and Danny Boozer's group in Journal of Dental Research in 2013, actually, I love this study because they really brilliantly showed the effect of the biotype and on dimensional changes. Actually, we did another study. It's going to be published very soon. It's almost the same study with some differences because we evaluated the effect of supracrystal tissue height also on these dimensional changes. But they showed that when you have thin biotype, the dimensional changes are significantly more comparing to thick biotype after extraction. So biotype is important, but how important is that? In this study by George Ferris and Jan Lindy's group, they showed that the socket wall thickness with less than 1 millimeters of thickness shows significantly more bone loss after extraction. So till now, we know that the biotype is important, and we know that the critical zone for us is 1 millimeter thickness of the buccal bone. But now the question is this: how thick is your buccal bone? We have tons of studies, histologically, radiographically, that evaluate the thickness of the buccal bone. And one of the landmark studies in this field is this one by Guy Heimbach from University of San Antonio, Texas, and Mariana Sanz group from Spain. They extracted 75 maxillary anterior teeth, they reflected the flap, and they measured the thickness of the buccal bone with the caliper. And guess what? In more than 70% of the cases, look here, the yellow one stands for the buccal plate thickness. And look, if we calculate these two together, in more than 70% of the cases, the thickness of the buccal bone is less than 1. So imagine, we said that 1 millimeter is critical, and in more than 70%, in some studies 80%, 90% of the cases, the thickness of the buccal bone is less than 1. And according to different studies, like the one by Uli Grunder, by Frank Spear, they all showed for success by Alberto Monge, for long-term stability, the minimum amount of buccal plate thickness that we need is 1.5. Ideally, we need 2. And if we look at this study, only 5% of the cases have 2 millimeters of buccal plate thickness. So it's a very important fact that we should take into consideration. So thickness of the buccal bone is a critical issue, and imagine that most of your patients doesn't have that thickness. So it shows that we should do something about it, do the grafting or etc. We should do something about it. So what is the blood supply to that piece of bone, that 0.5, 1, or 1.5 millimeters of buccal bone? Actually, we have 3 sources of blood supply to that piece of bone. One of them is periodontal ligament. So we talked about it. The bundle bone is PDL dependent. So when we extract the tooth by PDL, we don't have PDL anymore. So source number 1, done. We don't have it. What is number 2? The spontaneous bone, underlying bone between 2 cortical layers. So imagine we have 2 cortical layers, and we have a little spontaneous bone or trabeculate bone between them. So at least how much should be the thickness of the bone to make sure there is a very little spontaneous bone in between the 2 cortical layers? At least it should be about 1.5 to 2 millimeters, at least. But I showed you more than 70–80% of the time, the thickness of the buccal bone is less than 1. So this source number 2, done. We cannot really count on it or think about it. What is the last source? Periosteum. Okay, let's see what's the effect of the periosteum on making sure that maybe it can have an effect on saving this piece of bone. So factor number 2, facial flap reflection and the effect of it on dimensional changes of the ridge. These studies are the studies that evaluated the dimensional changes with flap elevation in the extraction sockets. And if you look at the numbers, all of these people were experts. So they're not beginners that you say that, okay, the surgical trauma was in the area or bad technique or less experience. No, all of them were experts. And look at the dimensional changes. The only difference with different techniques was that they reflected the flap and dimensional changes between 2.5 millimeters to almost 6 millimeters of collapse, just with reflecting the flap. So now what will happen if we don't reflect the flap? Other studies available that they didn't reflect the flap and measured the dimensional changes. The studies by Ule Grunder, by Lyndon Cooper, by Marco De Guidi, Ernesto Lee, Dennis Tarnow. Look at the numbers. Between zero point 0.1 to maximum 1 millimeters of change. And that 1 millimeters, believe it or not, is because of the bundle bone that we cannot do anything about it because it's PDO dependent. So by just saving the periosteal attachment to the bone, which is the, maybe we can say, the only available vascular supply to that piece of bone, we can minimize the dimensional change. So these days, for treatment planning, you have cone beam CT, you can do the sounding, you can extract the tooth atraumatically, you can evaluate the presence of the buccal bone with the periodontal probe, so to make sure that the bone is there and you can place your implants without reflecting the flap. So when you have all these instruments, all these things to evaluate the site, why you should reflect the flap if there is no need for doing the contour augmentation. And this is a study in 1995 by Manuel Chanavaz from France. They showed the anatomy and histopathology of periosteum and the quantification of the periosteal blood supply to that piece of bone. So we know that there is a connection. We know that there are vascular supply from the periosteum, and we should save it. And let's go to 2018, from 1995 to 2018. Flapless approach. This is a study by Joseph Kahn. They showed that, okay, flapless approach, simplify the procedure, reduce operative time, reduce patient discomfort, but preserve also the periosteum and supraperiosteal plexus. And if we speak about recession rate, comparing flap versus flapless, 43% versus 7%, almost 6 times more recession when you reflect the flap. So don't reflect the flap. This is the famous quote. I learned it from my mentor, Dennis Tarnow. So if it's there, if the bone is there, leave it there and don't disturb. Don't reflect the flap. So the aesthetic risks that we talk about, thin bone and thin tissue, which I'm going to talk about a little bit later. So speaking of extraction sockets, we have lots of classifications of extraction sockets, but one of the easiest one is this one by Nicholas Ilian from University of New York in 2007. According to this classification, we have 3 types of extraction sockets. Type 1, soft tissue is there and bone is there. It's perfect. Type 2, soft tissue is there, but bone is gone, like a dehiscence or something. Type 3, soft tissue and bone, both are gone, and you can see the obvious recession. So if we want to go with the predictable, predictable, you can do immediate in all these cases. But if you're talking about predictability, the best type is type 1 for immediates. Type 2, maybe I prefer to do the grafting, wait, and then come back. Type 3, definitely stage. In type 2, I will point a little to it, but some people do the augmentation at the same time and place the implant at the same time. But in the aesthetic zone, believe it or not, I'm not a fan of it because I don't want to risk. I want to make sure everything is there the way that I want, and then I can place my implant. So if you want to be, again, 100% predictable, type 1 is the best type of sockets, extraction sockets for immediate implants. What is factor number 3? Facial plate dehiscences, like type 2 sockets. What will happen if we want to place our implants immediately into those sockets, and is there any limitation or not? Again, lots of studies by Pascal Valentini, by Ronnie Young, by Steve Chan, Joseph Kahn, and lots more studies in this field. They showed that the presence of the dehiscences, when you go with the immediate implants, more early failures, more vertical and marginal bone loss, greater horizontal resorption, and higher incidence of recession It's possible. So it depends to you. You choose your patient, the case selection is yours, but we have these data available. And in 2014, Dennis Tarnow and his group published a technique called ice cream cone technique, using a rigid membrane in type 2 sockets to do the grafting of the socket at the same time. No implant at that time, but only the socket grafting. And they placed the membrane, they shaped the membrane, they placed the membrane, do the grafting. These cases are from the article, the original article. And you can see the dehiscences, they fix the membrane at the apical area with the mattress suture. The membrane should be cross-linked and rigid, not a loose membrane. Pack the bone inside the gap, inside the socket, and this is the results after 4 or 5 months. Sorry. You can see the dimensional changes from here, the start, to here. So even in the hands of the experts, that they showed the technique, the reach dimensional changes was about 1.3, even more than 1 millimeters. Maybe you say, okay, 1 millimeter is good, we can do the soft tissue graft at the same time. Yes, we can do. But what I'm saying is, maybe in these type of cases, if you cannot be able, or if you cannot be sure to minimize the loss, specifically because it's in the aesthetic zone, maybe if we go with the Danny Boozer's concept, it will be safer in type 2 sockets with dehiscences. So early implantation and contour augmentation maybe is recommended. But speaking of dehiscences, you should remember one thing. We have different type of dehiscences. We cannot say, okay, it's type 2, it's dehiscence, let's go with the stage. Sometimes you can go with the immediates, depend on the shape. And we have a study of that, a beautiful study by Joseph Kahn, and they evaluated the dehiscences with 3 shapes: V shape, U shape, and double U shape. It's like a wide U. And they showed if your failing tooth has a U shape or double U shaped defect as a dehiscence, it's contraindicated for immediate implant placement and provisionalization. If it's a V shape, you can go with immediate. So the type and morphology of the dehiscence is also important in choosing if you want to go with immediate implants or not. What is number 4? Number 4 is implant position. All right, let's talk about this one. First, let's talk about the size of the implant regarding to its positioning. Should we go with the wide implants? Should we go with the narrow implants, or with a regular size? According to this study by Marco Caneva and Klaus Lang's group, it's a dog model study in 2010, Clinical Oral Implant Research Journal. They showed that the resorption is always more marked, both at buccal and palatal or lingual aspects, if you use wide implants comparing to standard diameter implants. So we are speaking now more specifically, more focused on extraction sockets. So we don't want to go with the wide implants. We don't want to fill the gap, fill the socket completely with implants. We want to have more distance with the buccal plate, with the proximal plate. We want to have more bone at the end of the day, not more size of the implants. So this is only one study, and we have lots of these studies confirming this fact. Another one is about the position. And again, the same group showed that implants into the extraction sockets, it's preferable to go 1 millimeter deeper from the buccal crest and to place your implant not in the center of the socket, but more palatal to the center. Speaking of this fact, it's about routine implants that we have. Sometimes we have off-axis implants and the scenario will be changed. We can place in the center of the socket and the access hole will be in the cingulum. So it's a different. If we talk about different designs, maybe this fact can change. But overall speaking, with most of the implant systems, we don't prefer to place our implants exactly in the center of the socket. Why? Because we want the platform of the implant. If we go with the screw-retained prosthesis, we want the screw access hole in the functional cusped position, which in the anterior maxilla is the cingulum. So we don't want to be in the center, we want to go more to the palate. So where did that come from? 1 millimeter deeper than the buccal crest. Why not 2 millimeters deeper? Why not at the level of the buccal crest? This study by Cristiano Tomasi showed these variations and the best scenario that why we don't want to place our implants in the center, but we want to go more to the palate and a bit below the buccal crest. According to this diagram, which I recommend you all, if you haven't read it, please do. They showed that the best scenario for making sure that the prosthesis and the emergence profile is good, and also to make sure that the implant is not placed too deep, the best scenario is to place the center of the platform of the implant 2 millimeters palatal to the center of the socket and place the platform of your implant 1 millimeter below the buccal crest. Speaking of these evaluations, we are talking about type 1 sockets. The way that the buccal crest is in intact position, and then from that, we want to place our implant 1 millimeter below the buccal crest and 2 millimeters toward the palate to make sure that buccal plate can be saved as much as possible. And this is study by John Cousin. They showed that the midfacial recession, the most critical factor that had an influence on midfacial recessions, was buccally position of the shoulder of the implant, like this. We don't want to face that. So the odds ratio here, look at it, 17 times more risk for facing midfacial recession if your implant platform is positioned, tilted in the buccal aspect. So again, lots of studies in this field. Facially positioned implants, more bone loss. We don't want to face such outcome. Too many implants, wide implants, no attached gingiva, facially positioned. So all of them are those things that I mentioned that we are able to prevent the complications. So we don't want to end up like this, buccally positioned implants, bodily or tilted or etc. What is number 5? The fifth factor is the depth of placement. How deep should I place my implants? This beautiful study by Fernando Rojas Vizcaya in 2013, they showed a 3-2 rule, or 3A 2B rule. What is 3? What is 2? 2 stands for the distance to the buccal plate, which at the end will be the thickness of the buccal plate available. So we need to have 2 millimeters buccal plate thickness. Or we can say we need to have 2 millimeter distance from the buccal plate when we are placing our implant from its outer border. What is 3? 3 is the distance between the future margin of the crown to the platform of your implant. So why 3 millimeters? At least, you need to have at least 3 millimeters. 4 is perfect, but 3 is minimum. Don't even think about 2. 3 is minimum, 4 is perfect. Why? This is from Fernando's article. And look, if you have enough space, the lab technician has enough space, distance, to shape the emergence profile. And especially if your implant is platform switch, if you have placed your implant more to the palate, if you place your implants very superficial, there will be a ridge lap. And there will be not enough space for showing and creating a great emergence profile. And it cannot be a static tooth and reflect the way that it's coming out of gingiva. It's like a small tooth on the gingiva. But if you have that 3 millimeters, you have enough space to provide the emergence profile. I will tell you a little bit later in future slides that what is also again stands for 3 millimeter distance. So till now, again, as a conclusion, we can say that the bone resorption following tooth extraction is influenced by apicochronal and buccopalatal position of the implant, both, not only one of them. If you place your implant too superficial, the bone will resorb. Why? Because you need to have enough space for the biological width on top of your implant. My dear friend Thomas Linkevicius talked about zero bone loss concept. I really recommend you all to read that book. It goes in depth with all the details. But what I want you to remember is this: that 3 millimeters, we know it from 1960s with the definition of biological width. We should have 1 millimeter junctional epithelium space. We should have 1 millimeter connective tissue space. And we should have 1 millimeters at least for the sulcus. So biological width plus one, which is the sulcus, will be 3 millimeters. This is the minimum. We don't have any implants, exactly like any teeth, without biological width. We don't have it. So we should provide that space. If that space is not available, definitely body itself will provide the space. How? With bone resorption, with bone loss, and the exposure of the collar of the abutment, exposure of the threads of the fixture will happen, recession will happen, and etc. So positioning is very, very crucial. What is factor number 6? Factor number 6 is horizontal gap management. I love to talk about this uh, fact by referring you all to this beautiful human histological study by Steve Chu and Dennis Tarnow in 2011, Ron Nevin's journal, Journal of Periodontics and Restorative Dentistry. I just placed their case. This is a case report, but it shows it all. So they extracted a canine, they placed an implant in a perfect functional cusp position, and look at the gap size, 4.3 millimeters regarding the article. And they did nothing. No bone graft in the gap, no nothing. They just put a healing abutment. This is 1 week. This is 9 weeks, and the soft tissue healed all around that healing abutment. And now the question is this: what is underneath? Is it the soft tissue down there? Is it the bone there? Is it nothing? So what should we do? And this study, with the permission of the patient, they explanted that dental implant and evaluated the what is underneath, and that $1 million question. And look, bone up to the first thread. There is no way for the soft tissue to migrate to the gap. No way. Why? Because we have the blood clot, and blood clot is dead. And there is no way for epithelial cells to go to a dead piece. So what should happen? Exactly, it's biology. What is happening in the extraction sockets? When you extract the tooth, if you come back after 2 to 3 weeks, the socket is closed. If you take a radiography 4 months later, you can see the bone field. So is it an array to soft tissue to go there? No. That's the same thing. So from the inner aspect of the socket, first the young connective tissue will form, and the clot will resorb with the macrophage, and then simultaneously the epithelium migrates on top and close. So the worst scenario is the practitioner release the flap and close the socket with the flap, and accelerate the migration of the fibroblast cells. So with that said, do you think that we should graft the gap? Well, the answer is yes. Why? Because in this study, they showed if you don't graft the gap, you will face the collapse, the buccopalatal collapse. So we don't graft the gap to minimize or controlling the soft tissue migration down there. No, we graft the gap to minimize the collapse. And believe it or not, grafting the gap is more even important in less gap sizes, in little gap sizes, comparing to the big gap sizes. Because, for instance, this is a 4.5 millimeters of gap. Even 2 millimeters of collapse ended with 2 millimeters of buccal plate thickness. But if you have a very little amount of gap and the collapse happens, then it can affect the implant surface. So from the aesthetic point of view, we graft the gap to prevent the collapse of the ridge. And also in 2015, this is study by Maurizio Arujo and Jan Lindy showed that the grafting of extraction sockets does not per se prevent alveolar bone remodeling after extraction. It does appear to minimize buccal bone collapse. So it won't prevent remodeling, but minimize the collapse. and use of graft material in fresh extraction sockets cannot avoid bone crest resorption, but can significantly affect the volumetric reduction of alveolar tissue. That's the point that I want you all to remember. And this is like by Dennis Tarnow beautifully demonstrated that I just wanted to share it with you. This is the case that you place your implants and you don't want to end up like this. We want to prevent the collapse. What is factor number 7? Factor number 7 is immediate provisionalization. Should we provisionalize the case immediately? Does it have any effect on the final outcome? Well, I told you, all implants, exactly like all teeth, must have the biological width. And that biological width is the thickness of the tissue that protects the bone. And we know in our mouth environment, we have lots of microorganisms. So with those microorganisms, definitely we should have sulcus because we are not microbial free or plaque free. And this is studied back in 1996 by Tor Berglund and Jan Lindy. They showed the influence of lack of enough soft tissue thickness on crestal bone loss. And look, it was a dog model study. And in the left side of the screen, you can see in the cases, in one case, in the test group, the thickness of the soft tissue supracrestally was 2 millimeters. In the control group was 4 millimeters. And they evaluated 6 months later. Look at the control and the test group. In control group, the bone is stable. In the test group, you can see about 1.5 millimeters of bone loss to provide that 4 millimeters. So I told you 3 millimeters is a minimum. 4 millimeters is best. Soft tissue thickness on top of the platform of your implant. I believe that this is one of the most important points that I want you all to remember from this presentation. So this soft tissue thickness, we want it. And then we can shape it the way that we want. Without soft tissue thickness, you can't do anything. And speaking of all these protocols, grafting the gap, provisional restorations, primary stability, etc. This study in 2014 really compared all these things. In one of the groups, they had 4 groups. In one of the groups, they placed the implant in the correct position with a healing abutment, no provisional restoration, no grafting the gap. In group 2, they put the provisional restoration, but no grafting the gap. In group 3, they grafted the gap, but without provisional restoration. In group 4, they grafted the gap and put the provisional restoration. It was a multi-center study by Dennis Tarnow and Steve Chu from University of Columbia, by Salamo brothers from Atlanta, by Guido Sarnacchiaro from Argentina, and Hanai Saito from University of Maryland. So look at the results. This is from their studies, and look at the numbers. Look in this area, which is about 3 to 5 millimeters below the gingival margin, which shows the dimensional changes in the bone area, not in the soft tissue area. Actually, this article has many parts evaluating everything. So, but now I'm just focused on the bone part. And if you look, when they did only provisional, the collapse was about 0.7. When they only did bone graft, it was about 0.4, 0.3. When they did bone graft and provisional, the changes was almost 0. Imagine that, provisional and bone graft. But bone graft is one of the most important things that you should remember when you're doing the extraction socket and immediate implants. And in 2018, 4 years later, another group with exactly the same scenario did another study, and they exactly showed the same thing, that provisional restoration and grafting the gap shows the minimum amount of change, and grafting the gap was showed as one of the most important factors that can influence the prevention and minimizing the collapse of the socket and extraction socket and alveolar ridge. Number 8 is the presence of the interproximal bone. So what's the importance of that? If you look at the original article, landmark one by Dennis Tarnow in 1992, they showed that if the distance between, it was in the natural teeth, if the distance between the crest of the bone and the contact point is about 5 millimeters, almost 100% of the cases shows the papilla field. But look at these numbers. What if the distance is 6 millimeters? Only 56% showed the papilla field. When it was 7 millimeters, only 27% showed the papilla field. What I want to say is this. We can see the other side of the story. Imagine when it's 6 millimeters, 56% of the cases showed the papilla field. When it's 7 millimeters, 27% showed the papilla field. So there is something. We cannot say, is it 5 or is it not, and done. No. Even in more heights, papilla field can happen. So there is something else that we should think about it. What about tooth adjacent to implant? Another study by the same group. And look, when it was 3 millimeters and 4 millimeters, all the cases showed almost papilla field. But when it was 5, when it was 6, when it was 7 millimeters, at least some cases had papilla field. So there is something that we can do about it. And if we look about the importance of the distance, even in natural teeth, we have a horizontal relation of the distance on the papilla field. And look, the most common distance between roots was 2.5 millimeters. And when distance between roots was 2.5 millimeters, between the contact point and the crest, the average distance was 6 millimeters. So it shows the effect of the distance between adjacent tooth and the relation between the contour and contact point and the crest of the bone. So we can have it also on the implants. How? Let me talk about that a little bit more. In 2000, Uli Grunder showed that the most important factor that can have an influence on the presence of the papilla is the interproximal bone of the adjacent tooth. And can we say that if at the time of extraction I have the interproximal bone of the adjacent tooth, I can make sure the papilla is going to be there? Well, it's a critical factor, but I can't be sure if I place my implants too close to the tooth. And this study in 1993 by Marco Esposito showed that we have biological within a horizontal dimension. And Dennis Tarnow also mentioned that you should save that space from the adjacent tooth. If you get close to that peak of bone, which was present at the time of surgery, will resorb. So at first you had it, but now you don't have it. So when it resorbs, papilla will be gone. So distance horizontal is also the key. Speaking of conventional implants, without platform switching, this study by Dennis Tarnow showed that you should have about 3 millimeters distance between two conventional non-platform switch implants. Why? Because the horizontal dimension of the biological which is about 1.3 to 1.4 millimeters, is available and always exists around the implants. So if you place your two adjacent implants closer than 3 millimeters, that bone will gone. And when the bone is gone, tissue is gone. And according to Maurice Salama, he beautifully showed that when you extract one tooth, the period of adjacent teeth can save that peak of bone interproximally. But when you extract two adjacent teeth, the bone in the middle will gone because there is no source. So it's very important to make sure that we can do something about that piece of bone. And again, we have to remember, when we are placing an implant adjacent to a tooth, in the natural tooth, we have supracrystal fiber attachment to the cementum. But between two implants, usually we don't have it. So it's very important to think about this fact, and especially in the extraction sockets, it's very important to do something to make sure the tissue collapse is minimum. So can we minimize this gap? Yes, we can. With platform switch implants, we can minimize because we are bringing the abutments inward, we are bringing that connection inward, and we are providing more space. And according to this study by Luigi Canulu, they showed, it was a human study, the more the platform switch, the better outcome you can have. The last factor is soft tissue thickness. We talked about soft tissue more or less between the presentation, but as the final factor, To make it short, because I talked about it in different slides, the importance of soft tissue thickness beautifully demonstrated by Thomas Linkevičius during from 2009 till now with lots of studies. And I talked about biological width, I talked about the importance of emergence profile, connections, and he beautifully showed no matter what your implant system, no matter if it's platform switch or non-platform switching, soft tissue thickness is critical. And I told you why, because it's biology. We should back to the basics. It's biology. We should respect the biology and provide that space. And for confirming all this data, we have also other studies like this one by Wariki in 2014. They evaluated different abutment heights in overdenture cases, which reflects different soft tissue thicknesses. And they showed that when it was more than 4 millimeter abutment height, which shows more than 4 millimeters of soft tissue thickness, success was 100%, speaking of a level of the bone changes. But when it was less, the resorption was seen more. And this study, I just want you all to look at the conclusion, the one in the purple. Platform switching does not prevent crestal bone loss if at the time of implant placement, your mucosal tissue is thin. Again, platform switching does not prevent crestal bone loss if at the time of implant placement, mucosal tissue is thin. And thin is less than 3 millimeters. Why? Because of biology. Because we need to have biological width. And this is the, just to have a taste of the case, because I just wanted to show you the importance of these factors and not just sharing some cases with you. But this case had a lateral miss in the left part of the maxilla, tooth number 10, and tooth number 9 was extracted. You can see that there is an uneven gingival margin. And if you go to the CBCT, you can see that there is a concavity in the area, and it's the aesthetic case. So if you place our implants here, we're definitely going to face some fenestrations or dehiscences maybe. So here we decided to, number one, place the implant exactly in the functional cos position. Number two, do the grafting first, and then when we make sure that the bone is good, then maybe we can go with the soft tissue and then go for the prosthetic phase. So in such cases, using titanium mesh that are fixed on the top of the implant is one of the easy choices. Also, you can go with the Khoury technique and Khoury plates. But I found it in this case much easier because also the removal of these type of titanium meshes that are fixed on top of the implant is very easy. We just, there are some specific abutments for these cases, and that meshes will be screwed with that specific abutments. So with uncovering that screw, you can easily bring that titanium mesh out. And before doing the surgery, you've evaluated your CBCT and made sure that the bone has formed. And this is the provisional case of the patient, and the canine was reshaped to the shape of the lateral, and we should wait for the final restoration. So I just wanted to share this case with you to see that all these steps are important, and our strategies for maximizing success are, as a conclusion, are in these studies. Number one, let's go with the narrow implants, not wide implants, providing more buccal plate thickness. Number two, if the tissue is thin, let's graft the tissue, the soft tissue, and make it thicker. Number three, if your patient has a high aesthetic value in dehiscence cases, let's go with a delayed approach and contour augmentation. And number four, place your implants a little bit deeper and more to the palate in non-off-axis implants. So as a conclusion for immediate implants, the best case selection: intact socket walls, facial bone wall, at least 1 millimeter of thickness, thick soft tissue, no acute infection at the time of surgery, and availability of good primary stability and good eye skew. If your implant by any error and fault is too labial, let's go with the under contour restorations. If it's platform switching, the more platform switch you have, it's better to place it a little bit deeper and more to the palate. It's very important that the cervical contour of the restoration mimic exactly the cervical contour of the root that was extracted. Place your implants from the soft tissue crest, not from the bone crest, because you don't want to place your implant very deep. If you want to place your implant wherever the bone is, it will be too deep. So place it exactly the way it should be. And if you need augmentation, go for the augmentation. And if the buccal bone is there, don't flap. At last but not least, I want to thank you all for your attention. It was a great time joining you all. I hope that this presentation was beneficial for all of you. I really enjoyed my time sharing it with you. And also, I want to use this platform to invite you all to join my webinar series called Hot Seat with all these great names from around the globe. Every Monday and Friday, we will go live from YouTube, my YouTube channel. So looking forward to your comments and answer your questions, if any. And thank you again for joining me today in this live Facebook webinar. Thank you.
Thank you so much, sir, for the beautiful oration by you and the amazing cases you've shown us. And I'm highly excited, I was very excited to see all those cases and all those, the topic you've basically discussed and all the factors that have helped all of the dentists all around. So with this, we'll move on to the questionnaire.
Yeah, sure.
Okay. First question is from Dr. Rita. What is percentage of failure in your opinion?
On immediate implants,
I think she has not mentioned that, but she has considered about what is the percentage of failures in your opinion.
I believe that truly, I think the failure rates in immediate implants is completely comparable to conventional implants. And if we really take into the consideration all these factors that I mentioned for you as a checklist, we can have them. Where should I place my implant? What should be the soft tissue thickness? A surgeon exactly knows at the time of surgery that what is the soft tissue thickness now? Is it thin? I should graft it. When I don't do the grafting, I will face the failure or complications or not aesthetic results. So I believe that speaking of survival, speaking of success, is completely comparable to conventional implants. And if you want me to give you a number, I think 97, 98% is a good number.
97, 98% for the percentage of failures.
No, 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 for success.
Okay. Definitely. If
For
anyone is
success. For
following
failure
all
is
the,
like 2%.
sorry, sir, your voice is cracking. Can you just repeat
Yeah,
again?
for success, 97 to 98%, but for failures, it will be like 2 to 3%.
Definitely. If anyone is following all those correct protocols, right? Okay, so with this, I think we don't have more questions. Okay, we have one from Dr. Selby. What is your opinion on socket sheet?
Yeah, about the socket shield, I really didn't have enough time to go through that because first I wanted to add it, but there is so much to talk about it. Socket shield now is considered the most promising procedure that can give you the most predictable outcome, especially in the cases that you have thin biotype. Because I told you when you extract the tooth, you're eliminating PDL. So when you piece off the root shield in the buccal aspect, you are preserving PDL. You're showing the body in a way that the tooth is there, but it's not because you extracted the whole tooth and only the buccal part, which is your main concern, is there. So PDL is there, and according to the results by different studies by Baumer and Herzeler, by Howie Gluckman and Salama, Jonathan Dutoit, and so many other people around the world, the volumetric changes is minimum with socket shield. The only point is socket shield is that it's technique sensitive. You should exactly know what you're doing. And if you do the procedure step by step and go exactly with the protocol, the results are amazing. And the most importantly, it's reproducible. So it's not something that in one case is successful, in one is not. All the time, if you follow the principle, it's the best choice.
Definitely so. Okay. Next question we have from Dr. Mohit. Graft or socket shield for jumping distance? What will you prefer?
Can you repeat it again?
Yes, sir. Would you prefer graft or socket shield for jumping distance?
Actually, it's not something that we prefer. It's the surgeon's preference. Socket shield is a technique, and even with socket shield, we usually don't tend to place our implants in contact with the shield. So we can have again a space there, and we can fill it with the gap. So we can answer this question this way. Your question is like, do I prefer to go with the dual zone concept and graph the jumping distance, or I go with the socket shield? Well, both of these techniques works perfectly, and we have beautiful literature on that. But depend on the case. If your case is thin biotype, if you see that the extraction of tooth will put more risk on fracture of the buccal plate or any such risk, maybe the socket shield is a better choice. If you have more thicker biotype or you don't find any specific risk, maybe these techniques, both of them can be comparable. So it's mostly the surgeon's preference, but in highly aesthetic cases and in risky patients, socket shield can be more predictable, especially in the thin biotypes.
Okay. Next, we have from Dr. Ashwarya. Do you prefer partial extraction therapy in anterior region?
Yes, exactly. Actually, the best region for doing the partial extraction therapy is the anterior zone.
Partial extraction.
You,
Okay.
partial extraction is a comprehensive term. Socket shield is involved, pontic shield is involved, so it's a big term. Root submergence technique is involved, but in the aesthetic zone, usually we have more risks. So the most benefit that you can have from partial extraction therapy, I can say, is in the anterior zone, aesthetic zone.
Okay. Definitely. So, what did you tell about what two things are involved in partial extraction, socket shield and
Pontic shield.
pontic shield? Okay. So, we have the next question from Dr. Nishan. What classification for sockets was used?
Here in my presentation, it was a
Yes.
classification by Nicholas Ilian, which we had only three type of sockets. One is bone and soft tissue intact. Type 2, soft tissue is intact, bone is gone. And type 3, both soft tissue and bone is gone. So it's in 2007, if you want to look at it, by Nicholas Ilian and Dennis Torna
Okay.
and Sanction Cho.
Okay. And I think we are, less with time, and we have a lot of regards for you also, so for the lecture. Okay, we'll take one question now. Again from Dr. Nishant. Which technique you use for restoring soft tissue thickness?
For restoring soft tissue thickness, usually in the aesthetic zone, the best approach, I believe, is the tunneling. So have an envelope flap and insert the connective tissue graft inside the envelope to thicken the tissue in the buccal aspect.
Okay. So thank you so much, sir, for the beautiful cases you presented and the oration and the knowledge even you shared, which can be helped by everyone. So with this,
Thank you.
yes, sir. So with this, I would like to end the session for today. And I would like to guide all the participants. Kindly visit www.gomha.org for further updates regarding certificates as well as speaker schedule. So we'll be back in a moment with our next interesting session by Dr. Zip. So kindly stay tuned. Thank you so much, sir, for the session.
Thank you so much. Bye bye.
Stay safe, sir.
Thank you. You too.